let's go back to some basics. And this is one kind of a cell, and it's axon. We might have forgotten it, but let's revisit these words. There is a nucleus, there's dendrites, and there is an axon, which is quite long when we talk about peripheral nerves. And these peripheral nervous system is outside the blood-brain barrier. So that's the basic difference between the sensory system and the motor system. The motor system is quite inside the blood-brain barrier, but peripheral nervous system is outside the blood-brain barrier. So these peripheral nerves, and when you talk about lower limbs and the legs, these are long kind of axons. So the length of the axons is much long, and they are quite away from the original cell. And that may be one of the reasons. So one, it is outside the blood-brain barrier system. Secondly, very long axons, especially in the lower limbs, much longer than the upper limb. The cell body remains quite high and there's a long axon. So they are kind of a more vulnerable to any injury. And that's the hallmark of, peripheral neuropathy, how they get damaged. Then one more thing, when we talk about different sensations, so there are myelinated nerve fibers and there are unmyelinated. So some axons are not myelinated. Like suppose you see this figure. So for example, these are the myelin sheaths over the axon. So when we see the sensation in the peripheral nerves, as we see the touch, a simple touch, then we know the temperature sensation. Then we check in our peripheral neuropathy system a simple vibration sense, position sense, deep touch, which we take by monofilament, and we also see the position sense. Shripad, I am just introducing introductory slide of this, which I am just introduced about long axons in the peripheral nerves. I said these are outside blood-brain barrier so that they are more vulnerable to injury. And the smallest or the unmyelinated fibers which get affected, they do not have these coverings. And so they are more prone to any injury. They have less mitochondria. And that's why they are more vulnerable to all the toxic injuries, which is not only glucose, but the lipotoxicity, reactive oxygen species, and so many of them. So let's visit these basics from Dr. Pujari. Let's understand that. Yes, Dr. Pujari, go ahead.
Yes. First of all, thank you very much for that kind introduction from Kaya Madam. And it was really good to know that I would be teaching basics, because that is what now, as she said, in the neurology training, we should begin with. And once that foundation is laid, that we get to understand the diseases very well. So my beginning slide will be sensory symptoms itself. So we classify them as negative symptoms, which means decreased sensory discrimination and elevated thresholds such as numbness, in case of what Madam said, small fibers, and usually sensory ataxia, which means the patient feels that his balance is getting lost, and even worse when he is trying to walk in the dark. And positive sensory symptoms, which means something active the patient is feeling, either in the form of dysesthesias and paresthesias and neuropathic pain, which we are going to, try and understand these terms, because if you read any article or book on neuropathy, these are the common terminologies that are mentioned. So dysesthesia is an abnormal perception of sensory stimulus, and in case of large fiber it would be tingling, and small fiber either in the form of burning or pain, as you very frequently hear from your patients. Then paresthesia, which is an abnormal sensation similar in quality to dysesthesia. Hyperesthesia is increased sensory experience with stimulus. Hyperpathia is augmented pain. So say pain may be 4 out of 10, actually the intensity of pain, but it is felt as even worse. And then I just said sensory ataxia, which leads from loss of proprioception, joint position sensory input. And it is experienced in localized regions of the skin and affected by most of the peripheral neuropathic processes. Now, But remember, similar symptoms can also be seen with spinal cord and cerebral disorders. And in another important point, basics is the pathogenesis of such pain. There are three mechanisms. First is lowering of the membrane potential, leading to excessive discharge of the damaged neurons. Then membrane potential instability and crosstalk, that is epileptic transmission between the damaged axons. And as madam just showed you, the same thing I'm going to show, the reflex arc beginning with the skin through the sensory nerve fiber at the dorsal root ganglion goes into the spinal cord, and then there is interneuron connections between the sensory and motor neuron, but there is also the monosynaptic reflex arc, and from there the anterior horn cell fires into the axon and produces contraction of the muscle. So this is the basic reflex arc that works either as a monosynaptic or through the higher centers. And we all know, as madam just said to you, we have these sensations: the pain, temperature, joint position, vibration, pressure, fine touch, and stretch. And we are going to see very briefly but neatly the sensory receptors and the nerve fibers. The first slide consists of the sensory receptors. Just pay attention to this column: large diameter myelinated nerve fibers, which carry either touch and vibration or joint position and rate of movement, are transmitted either by the Pacinian corpuscle or the Golgi tendon organ. And don't forget, even the muscle length and contraction, that is our ankle reflex that you take, also goes through the large fibers. And the receptors that you stimulate are the muscle spindles, as you know. And then with the small myelinated and unmyelinated fibers, the strong tactile and thermal means the pain and temperature stimuli, which go through free nerve ending as well as the Merkel's disc. And then there are the lightly myelinated, which also carry touch. So there are crude and fine touch, and the other touch is carried by the Messner's corpuscle. And here is the second slide, which gives you the diameters of the nerve fibers with its velocities. So the heavily myelinated carry at 70 to 100 meter per second, carry both the proprioception as well as the muscle reflex arc, the new terminology being 1A, 1B. And then the medium myelinated carry the touch, pressure, and again a form of proprioception. And they are lightly myelinated. The new terminology is 2. And the 3 and the 4 are either lightly myelinated or unmyelinated. They are the slow fibers, as you can see. They carry the pain, temperature, and the pain and the temperature mainly, and the crude touch. So we have the small fiber neuropathy, which carry the pain, temperature, and the crude touch, and the large fiber, which carry the joint position, vibration, pressure, fine touch, and the stretch. So signs of neuropathies and relevance of investigations. As madam just said, small fiber neuropathy will cause loss of temperature, pain, and crude touch in a stocking and glove distribution, whereas the large fiber will produce loss of joint position, vibration, pressure, fine touch. Again, if it is length dependent, such as, for example, diabetes or B12 deficiency or things like that, again in the stocking and glove distribution. And as you know, the Romberg's sign will be positive. And in case of large fiber neuropathies, the ankle jerk, the deep tendon reflex, will be absent, whereas it will still remain preserved with small fiber. As madam just pointed out, very important point, that most of the times it's only the pain and temperature, if you check, that will be abnormal. Even the ankle jerk will be present in the classic diabetic small fiber neuropathy. And even the quantitative test, sensory testing, such as the vibration detection threshold, monofilament sensory testing that we test at the bedside, can be initially normal for a few months to years. And even the nerve conduction velocity, because it predominantly assesses the more myelinated fibers, can also come normal, at least during the initial stages of such diabetic neuropathies. So I'm going to finish by just showing two simple tables. If you have to think of nerve diseases, this is the way you think. Mononeuropathy, majority are due to pressure, entrapment, and trauma. Mononeuritis multiplex, vasculitis, Hansen, sarcoid, diabetes. And then the polyneuropathies, that is affecting all four limbs symmetrically, starting with legs and then ascending to the arms, predominantly motor, it's GBS or CIDP. And then in the sensory, this is the most important part of the table for us. The differentials of diabetes include alcohol, vitamin B1 and B6 deficiency, HIV, amyloid, and certain inherited disorders such as Fabry's, Tanger's, and hereditary sensory autonomic neuropathy. Today, we are not going to touch upon the large fiber because today's area of interest is the small fiber neuropathy. So the same list I have highlighted again, and I think, but remember, it's not exclusive for diabetes. Diabetes produces a host of neuropathies, and under symmetric neuropathies, the commonest that we are going to talk about today, the distal sensory neuropathy, which is the small fiber one, and along with that you can have large fiber, and in the small fibers even the autonomic nerves will get involved. And uh, you can also have the asymmetric neuropathies. You all know the amyotrophies, which is called as a proximal motor neuropathy, which affects the lumbosacral plexus and the femoral nerve. And you can, have a truncal neuropathy, a pain produced like shingles, herpes zoster. And then, you can have cranial single neuropathies like Bell's palsy, third nerve palsy, and even limb mononeuropathies. And rarely, inflammatory polyradiculopathy can exist along with diabetes. I think, yeah, that's what, ma'am. There is another slide. I have prepared a slide on pathogenesis of diabetic sensory neuropathy, and I leave it to you whether you
Please,
want
please.
me to address it
No,
or.
go ahead. If you have one slide,
Okay.
please go ahead.
So yes. So basically, as you know, there are several mechanisms by which nerves get damaged in diabetes. The most popular one, aldose reductase inhibitors have gained a lot of popularity, although we don't have a really very safe as yet drug to prescribe. But we should know the mechanism. It produces sorbitol, which converts to fructose, and through osmotic mechanisms and other mechanisms such as reducing the enzyme activity such as protein kinase and NAK ATPase activity, it causes dysfunction of the nerves. And then there is also, we all know this term, non-enzymatic glycation of the structural nerve proteins. Hyperglycemia by itself damages through rheological changes, increases the endoneural vascular resistance, as well as auto-oxidation of glucose, giving rise to toxic oxygen-free radicals, we all know. And insulin deficiency by itself alters neurotrophic factors, and all above changes lead to axonal as well as Schwann cell metabolism alteration and impaired axonal transport. I think that's all what I wanted to say. Thank you very much.
Yes. So as we all know that diabetes dilemma is mainly the discussion, and therefore we will be doing whatever we just discussed from the some points. So my what I wanted to make point from the basics is that it's mainly a small fiber neuropathy, which patients come to us with those strange sensations of pain, which may be neuropathic pain, and some strange sensations of leg pains or the balance loss. And what we check, even a simple neuropathy screening in the clinics, we know that 10-gram weight of monofilament, which we check, or we check the tuning for the vibration sense, position sense, and ankle jerks. All these things they check the large fibers. For small fiber, it's actually pinprick and just the feeling of the cold, that is temperature. So if we give a cold key or a tuning fork or touch it, mainly in the feet, if patient can differentiate, which is slightly not easy. So the point here I'm making is it's very difficult to diagnose small fiber neuropathy by any signs or by checkup. By the time we send patients for nerve conduction velocities, I think it's like Shripad, what do you check when I send a patient to you for NCV and the EMG? What do you check in that?
For diabetic small fiber neuropathy, as I said, in the first sort of between first 6 months to up to 4 to 5 years, the because this is the limitation of nerve conduction study. which predominantly assesses the large fibers during the initial up to 3 to 5 years, the standard nerve conduction study can still be normal. And as Madam rightly said, if we check vibration, as I showed you in our back to basics, the vibration is again carried by the large fibers. So, but but part of the vibration is also carried by the lightly and medium myelinated fibers. So you may find impaired vibration threshold, although the vibration may still be perceived, but the threshold may not be as normal as a normal individual. But at least during the initial stages, the nerve conduction study can be normal, and even the monofilament threshold, you may just find maybe mild to moderate changes. So I am referred patients at times. I say we may do nerve conduction study say after 6 months only if your symptoms are not controlled, and if your symptoms get controlled, we may not need to do the nerve conduction study. So we rely mainly on uh, the patient's symptoms, the characteristic symptoms of the burning, pain, dull pain, discomfort in a stocking glove distribution, the duration of diabetes, and the HbA1c, and these kind of parameters.
So this is the hallmark for everyone. We know that it starts, these signs and symptoms progress from the feet upwards into the leg and reflect a distal to proximal fiber loss. That is the hallmark of diabetic peripheral neuropathy. So usually it always starts from the distal, it's bilateral, symptoms are present, and that is the main hallmark. Clinically, if we want to pinpoint towards a diabetic peripheral neuropathy, and as we discussed, what the point I wanted to make, that signs may be absent, tests may be absent. It is just the clinical diagnosis, talking to the patient, asking him positive questions so that we get the more information. History taking and talking to the patient is more important to diagnose diabetic peripheral neuropathy in early stage when the patients suffer more. Now, one more thing. These are the metabolically healthy nerves. Just we saw that axon, long axon, and the nerve cell, dendrites, and the myelinated sheaths. You can see there is an obese individual. We may be having frank diabetes or just pre-diabetes and obesity. And you can see that pictorially in a cartoon-like fashion, it was shown that this myelin sheath is distorted. So there is a injury to this. So now, up till now, the whatever we got education as microvascular complications, that mainly peripheral neuropathy, retinopathy, they are correlated with HbA1c and the hyperglycemia. And now more and more evidence is coming ki it's not only A1c. It is not only A1c. You know, 20 to 30% of newly diagnosed patients of type 2 diabetes have peripheral neuropathy. And even though there is a good A1c control, there will be some damage to these peripheral nerves, which happens because of lipotoxicity and all the things which Dr. Shripad just now mentioned. So, obesity, dyslipidemia, energy overload, reactive oxygen species, which is having because of some hypoxic damage, impaired mitochondrial trafficking, which is more is seen in small fibers as there is no myelin sheath and the axons are long, so which is there in diabetic peripheral neuropathy. There is a nerve cell apoptosis happens with all these injuries, and mitochondrial depolarization, inflammation is also, and as well as hypoxia with hyperglycemia. So it's not only glucose. So there are multiple reasons other than A1c control which may be responsible for diabetic peripheral neuropathy.